Hello viewers, I am Dr. Jung Young-eun. Did you have nice Lunar New Year holiday? I really had a good rest. Our masters, Dr. Kim Kyung-won and Dr. Kim Gi-sung. Hello. Hello. Did you have a good rest? Yes. Actually, due to COVID-19, it was hectic, so I hope we can go back to normal. We have a new master for this case discussion, Professor Kim Young-taek. Hello. As a periodontal master, I believe he will give us very good explanations. What's your first impression? It is my honor to be with these experts. I have about 15 years of periodontal experiences. I will try to share my experience with you.
네, 감사합니다.
Before we start the case discussion, if you're watching this on Daniel's site, on the right-hand side, you will see the chatting window, and if you have any questions or comments about the cases under discussion, please post them on the chatting window in real time. Today's case, 66-year-old female patient. She has hypertension, diabetes, hyperlipidemia, and chronic kidney disease. She has maxillary implant overdenture and the mandibular RPD fabricated 2 or 3 years ago. The upper denture does not have a problem now, but she wants to place an implant to get more solid prosthesis before she gets too old. She wants to keep the lip support of the denture she is currently using. To make the implant prosthesis to keep the lip support in the upper edentulous area, how can it be done? That is a story from the patient's dentist. Here, 13 and 23 implants are used for the overdenture, and there is teeth-supported RPD in mandible. As there is the alveolar ridge in the maxilla, implants can be placed there. Lips are influenced by the teeth and the alveolar ridge. This is very challenging because we need to provide the lip support in the upper edentulous region. What do you think? Shall I go first? It depends on the patient. Various options can be available. I don't think this is a really challenging case. I will explain with the clinical cases later. Then, this is my first time here. Let me explain something first. Implant-supported prosthesis. I am working for the government, so I want to clarify the correct terms, whether I use the correct terms. So there are terms used by prosthodontists or the general dentists. Fixed dental prosthesis. I read the case under discussion. She wants fixed prosthesis. She likes the denture, but usually patients cannot think of lip support, so that's the kind of fixed dental prosthesis. Implant-assisted RPD is widely used, so sometimes it is called implant-assist or implant-assisted RPD. Implant-retained overdenture. This is using a small number of implants. Implant-supported overdenture. These are commonly used terms. I looked into the terms. According to the Journal of Prosthetic Dentistry 2017, omni-implant-supported crown, implant-supported denture, and implant-supported prosthesis are officially defined, and the rest of the terms are not official, even though they are used in papers. So they are not fully defined, but it is interchangeably used, commonly used. So going back to the case, if you take CT images and look at the dentition, there is a big gap between the lip support and the bone. we need to accommodate the request of the patient. We could remove the implants, or we can use the 13 and 23 that are remaining. We can do GBR bone graft. So we can provide the fixed prosthesis. This is a similar case. There's such a gap. The fixed type is very challenging. So for this case, I'm a perio surgeon. I would place 2 or 3 more implants to provide implant-supported prosthesis. If the patients wants, we can go for hybrid as well. I would like to share a very challenging anterior case of mine. The patient came to me in his 40s 10 years ago. Anteriors were mobile, so they were extracted, and implants were placed in other areas as well. Because of the periodontitis, the bone is seriously resorbed in the anterior region. Horizontally, actually the arch is contracted inward. So due to lack of bone, I told the patient that it's difficult to place implants. We always need to lower the expectation of a patient, and we are not confident in doing so. So I told her that GBR will be done with the placement, and GBR will be done additionally later. So implants cannot be placed here. As a periodontist, I GBR a lot instead of a block bone graft. Xenograft and cross-linked collagen membrane are used. To augment horizontally, a tent is needed. With bone good material only, it can collapse. So tenting screws are used, and membrane is covering the site, and we waited. I believe I waited for about 5 months, and it is opened again. You can see the bone formation. The screws are removed, so it is augmented 1 centimeters upward. If you look at the surgical stent made for the final prosthesis, still the bone is very deficient. So it would be hard to fill the gap that much. Implants are placed because there are available bone for the placement. So it is labially placed at 3 to 2 locations, and the bone graft is done again additionally to augment horizontally more. So implants are placed, and the final prosthesis is delivered. After 6 months, the gingiva and the arch are retracted. So horizontal augmentation has so many limitations, and we can repeatedly do the bone graft, but it is very difficult for the patient. So using the remaining teeth, we can raise it just a little bit, but if you look at the case under discussion, this may not be appropriate. It is maintained for 5 years, but if you do GBR, the prognosis can be poor, so this is questionable. Dr. Kim Kyung-won, I have a similar case. This patient, we didn't have digital panorama at a university hospital that I worked before, so these are the analog pictures. It was like this at the initial visit. We considered implants, but all of them need to be extracted, so we thought about temporary. 4 implants were placed for overdenture. A kind of a bar attached to overdenture were considered, but patient used the temporary, and she didn't really like it. She was not very old, but the jaw bone is quite reduced. So we placed 4 implants on the maxilla, the old US type. On the mandible, 6 were placed because the patient wanted a fixed type. I thought about hybrid type. Using sinus crest approach, 2 more were placed at the maxilla, 6 and 6 on both jaws. This is kind of a hybrid. Now gold is very expensive, but at that time gold was used. The picture is not clear, but the patient wanted to switch it to fixed type. But later she said her lips are wrinkled and look older than when she was wearing temporary. Chewing is much more comfortable, but she looks old. It was her choice, so it was not a problem, but the anterior prosthesis was very challenging in this case, even though I didn't do it myself. So just like the case under discussion, when lip support is important, you talked about hybrid type. Even hybrid type is not good enough to give the lip support. So here, this is the follow-up of 6 years and 5 months. The patient was satisfied. So this is the case, older case using Nixtrona type. Another case, at the initial visit, she used maxillary full denture for 10 years and she was in her early 60s. She really wants implants and she visited many clinics and she realized it's not possible. So she wants fixed denture. She used the denture for 10 years, so the jaw bone got reduced and the tissue got movable. So we took the CT images, the medical CT, not cone beam CT. A lot of bone resorption on the maxilla because of denture. It wasn't really good to place implants. I opened it. Like the previous case, I told her that the fixed would be difficult and the 4 were placed and the fixtures were exposed, so bone graft was done. It was early days of Ossbuilder. I don't have a good memory of titanium mesh when I used it in the 1980s, but at the time, this was called the Smart Builder and it was pretty good to use. So 4 were used. At that time, I just used allogenic bone. So 4 Ossbuilders were used for the ridge augmentation. The patient had to use a denture, but if it is supported by implants, it would be more stable for the denture that she was using. In the second surgery, the bone was formed. You can see the bone was formed compared to the time when the surgery was performed. Like this, using the locators, 4 in maxilla and 2 in mandible. I believe Dr. Kim Ki-sung doesn't like the locators. I'm not a prosthetic expert. After a year on the maxilla, it is a little bit resorbed. After 3 years, only allogenic bone was used, so it is resorbed, but the patient is satisfied. Compared to the previous denture, this is much better. So she's happy. She didn't want a denture from the start, but even hybrid cannot provide the lip support. Even with the GBR, the lip support could not be achieved. That's why we did it like this. So I felt from this case that I only used the allogenic bone with Ossbuilder. During the follow-up, it is resorbed. So when I use an Ossbuilder, I use allobone inside and xenogenic bone outside in a layered sandwich approach. And the space can be maintained and it can last longer. For the case under discussion, the patient doesn't want a denture, but if you consider lip support, you may have to go for denture. For my internship, I chose full denture. It is a subject of prosthodontics I chose it not because I liked it. I thought if I chose that, I could learn implantology, but it was not the case. Even now, if a patient comes who never used a denture, the full denture cannot satisfy the patient in whatever technique is used. Now, with the widespread use of implants, it became easier. Full denture is difficult in mandible, so the answer for that is placing two implants on mandible like this. Locators or other attachments can be used. If you have a small number of implants, for the maxillary overdenture, that is the issue. For this, there is a controversies in papers because overdenture on maxilla has high rate of failure. So the papers acknowledged using 4 implants, implant-assisted overdenture. Otherwise, there are high rate of failures. I don't have a case. From the textbook of Osstem, this is a case by Dr. Che of Hanbit Dental Office. This works. There's a consensus among the papers. Here, 2 or 4 implants can be placed on the maxilla, and using locators are not recommended. But if they're connected like at the bottom, it's okay. However, distal extension is not very favorable. I don't really hate locators. I like them in the mandible, but I was really in trouble in this patient, so I hate the locators. The problem is with the opposing teeth. Our masters showed very good long-term result when the mandible had denture as well. Here, mandible teeth exist, and overdenture was done on the maxilla. 3 locators attached to the implants, and I was very happy when I took this picture. It was my very first case, and I thought the patient would use it very well. But implants with locators failed, so I placed implants again and attached the locators. The result is like this. The locator attachments are worn out. On the right-hand side, the young denture became very old. So many complications, and the patient comes back to me frequently, and I want to seek alternative treatment, but the patient got used to this and she doesn't want anything else. For the case under discussion, if you place many implants and if you make fix the prosthesis, if it provides lip support, it would be aesthetically very good too. But we cannot do this in many cases. If the denture has been used for a long time, it's not possible to do this. As a prosthodontist, I cannot do GBR as good as our masters here, so I have to choose something else. Rather than fix the prosthesis, I usually choose implant RPD. I am keenly interested in this, and I have a lot of cases of this. In 2005, the experience started here. The denture patient lost teeth. Denture was attempted with implants. At that time, I had never seen a case where implant is used for surveyed crown and denture. And the denture was made like this, but I couldn't show that to anyone else because it was not a common procedure. But now it is becoming popular, so I'm introducing my old case like this. The patient is using this really well for more than 2 decades. There are 6 implants and it has very good lip support. In 2016, more implants are placed, and the patient is 70 years old. It is used very satisfactorily, so I thought this can be used in old patients more. So if you look at here, it has been used for a long time. So the same procedure is applied to this patient. For an edentulous case, full denture can work very well when denture is there in the mandible. Here is my favorite approach. 2 implants are placed at each side. The locations would be 3-4 or 4-5 or 5-6. Wherever the bone is good and surveyed crown is made, zirconia or PFM can be used to make the surveyed crown. For the RPD, this is a denture providing good lip support. Here, the anterior clasp is not made, so it is aesthetic, but anterior clasp can be used for old people. 62-year-old male. If someone is over 65 years of age, when there is natural tooth, the procedure is covered by the National Health Insurance, so this can be used pretty effectively. I like Osstem's one-guide guided surgery system. Using the guided surgery, we can find good bone. So 82-year-old male, teeth got destroyed and implants need to be placed. There are 2 teeth left. RPD cannot be done, so on the other side, implants are placed. And implants are placed at the left as well. RPD is done. Guided surgery can be used for accurate positioning. Surgery is performed. If necessary, I raise the flap, but as much as possible, when bone is good and soft tissue is favorable, I go for the flapless surgery, which is less painful and the outcome is very good. So surveyed crown is used. In this process, the denture should be connected to the implant prosthesis. Therefore, prosthodontic steps are required. That is very important. Therefore, you need to be skilled in the prosthodontic steps. So surveyed crowns are made. Osstem has ER type with holes in the prosthesis. So from here, it's general RPD. The patient is using it really very well. Considering this, if you look at the case under discussion, my favorite implant RPD can be used. This is denture. It provides lip support and good function. So this is the diagram that I made. Number 13 is not very good. In this case, the locator may not be used here. What is important is 4-5 is used for the surveyed crown. For the RPD, this is not an overdenture, so chewing function is much better. I believe this is a good option. What about number 13 and 23? I don't use locators there. If you use locators, actually it limits the direction of denture insertion and removal. And the middle portion of them would be filled with resin and that they need to be buried. So they're in a sleeping status. Yes. Not many doctors have tried this. Many people are worried that may give too much burden on the implants. I think this is excellent because I have used it in more than 50 cases. I strongly recommend that. You have already 3 and 3 implants, so you place 4-4 or 5-5. Looking at the case under discussion, number 13 and 23, I don't think the directions are good. And at number 3, clasp should be there, so it is not good there. May I ask a question? Implant supported overdenture. No, this is RPD. Tissue support. So you have been successfully doing this, and I believe this is backed up by evidence. Do you have any know-how for impression taking? It is like general RPD. Implant RPD is a little bit different. As teeth are lost, the bone is resorbed. Where implants are placed, a surveyed crown needs to be made. It is palatally positioned. When the clasp is applied, the buccal volume would get huge. For implant RPD, you need to take very accurate impression taking. Natural teeth have a periodontal ligament which moves just a little bit to accommodate the errors in the RPD, but implants don't move. Therefore, if RPD does not fit perfectly, it will be a problem. Impression taking is a little bit tricky because there are many undercuts. So that is tricky. So we cannot apply this procedure to a site where extraction was made a long time ago. So it's difficult to make the surveyed crown. If it is not properly done, the neutral zone can be invaded, which is a problem. So we need to be careful about it. This is good to use when teeth were extracted just a short time ago. Thank you very much for the good tip. The tissue supported and the implant supported, basically the RPD process is the same, isn't it? Yes, it is. Let me ask a question. I use the locator in my case. I do the surgery and prosthesis is done by the private practitioner. As you said, 2 locators can be done on the mandible and on the maxilla. Bar attachment is used. When I discuss this with many doctors, the lab process of bar attachment sounds very challenging, so they tend to use locators on the maxilla. Do I need to tell the prosthodontists to use bar attachment on the maxilla? No. After overdenture, it is recommended by the papers, but the bar attachment requires very complicated prosthesis process and the lab cost is very high and it's hard to modify. It is recommended by papers, but I've never used the bar attachment myself. I always use implant RPD. We have separate prosthodontists. The magnets have been advanced quite a lot since neodymium, and they say magnets work very well. In the past, I was negative to the use of magnets. I haven't used it recently. The magnets have advanced pretty good and some people like it. So the lab process is very simple. I don't intend to use a bar attachment, but magnets would be better. I work with the GP as well as prosthodontists. As I remember it, bar overdenture was used at the end of 1990s until early 2000s, but it went away because of corrosion and other negative problems. And bar attachment was used, but the lab process is very complicated. And gold is too expensive and it uses non-precious metal. That's why locators are used these days. According to Dr. Kim, people may get the idea to do implant RPD. Prosthodontists that I work with begin to recommend RPD instead of overdenture. So if you make a lot of presentations, many dentists would be helped. Yes, I can see many people begin to use this. listening to the explanation surgically, prosthodontally, psychologically. We need to consider many things for treatment planning. Would you give us closing remarks? These days, we have guided system, and when implants are precisely placed using the guided surgery, I believe various procedures can be employed. As I said before, if you look at the case under discussion, the ridge is resorbed as edentulous region continued for a long time, and the jaw bones contracts. When there's a natural teeth on the opposing arch, crossbite can happen, and lip support is challenging, and the prosthesis is difficult, so removal RPD can be an option. GBR augmentation to recover the bone is very challenging. When ridge is severely resorbed, implants placed on the maxilla tend to have angulation problem and labioversion. As I said before, in this case, from the surgeon's perspective, we get ambitious. There are many surgeons who are very skilled, but being too ambitious would not be good. I work with the prosthodontists and I get ideas from them, so there can be many ways, and I hope the dentist who sent us the issue considers many different options, and we shouldn't be obsessed about using the implant placed there. It can be in a sleeping status, or we can remove them. So in this case discussion, we talked about prosthesis to maintain lip support of maxillary edentulous patient. It is a challenging case, and I hope this has been helpful to the viewers and the dentist who sent us the issue. Thank you very much, masters. I am Dr. Jung Young-eun. I'll see you next time. Thank you.
수고하셨습니다.